Good morning, everyone. This is Sandy Atkinson with the Iowa Healthcare Collaborative, and we are going to get started on our topic today, which is sepsis. So just a few housekeeping items. Please make sure your phone lines are on mute. Don't place the phone call on hold. Please utilize the chat box for questions and responses. And then the session is being recorded for purposes that we'll be able to send out a link. This is the 5th webinar in the HAI Superset series. And just a quick reminder, jump starts are opportunities for facilities to gain fresh ideas, provide peer perspectives, energize your infection prevention teams, and stimulate action around your infection prevention efforts. So before we get started today, I want to walk you through a few brief housekeeping items. Attendees are automatically muted. However, we highly encourage you to interact and use the chat box, which you see here, to ask questions during the event. The chat box can be accessed by clicking the chat button at the bottom of your screen, and it's circled here. And then before entering a question into the chat box, please be sure to select Send to panelists and attendees so everyone can see the questions. I will be monitoring the chat box throughout the webinar today. I also encourage you to use your phone or computer audio, but not both. If you use both, you will encounter an echo when you're listening to me speak. And so now to get started, using the chat box, who do I have in the room today? Please enter your name and your facility into the chat box. Morning, Lexi. Hi, Tanya. Hi, Tiffany. We have Chris from Newton, and we have Karen from Waverly, Cindy from Henry, Sherry and Emily from Dallas County, Joan from Regional, Joyce from Lucas, David from Mercy One Skiff. We have the sepsis team from Winneshiek, Lori from Washington, Jenna from Cass County, Michelle from Lakes Regional. Good morning, Kate. Well, thanks so much for taking time out of your busy schedules to join me today. Just to get to know you a little bit. Hi, Kara. What one tradition do you always celebrate at Thanksgiving? What's the one thing you can't do without at Thanksgiving? You go around the table and say one thing you're thankful for. Pumpkin pie, large meal with family, sharing what you're grateful for, eating pumpkin pie, watching the Macy's parade. I love that too, Maggie. That's awesome. Family. Family and pumpkin pie, gathering with family. Yep, I agree with all of those. Football. Why does that not surprise me with you, Sherry? Sweet potatoes. Yeah, there's just so much good food. And I think for me, I think the thing that makes Thanksgiving most is, like you've all alluded to, it's spending time with family. I think that makes the food taste so much better until you drop the dressing on the floor. I'm raising my hand because I've done that before. So, okay, we will get started. Thanks for sharing, guys. So our objectives when we're talking about sepsis, the post-operative sepsis and septic shock, is why is this important? And key elements to prevention, risks, the SSI bundle components, because it is an important part when you're dealing with post-operative sepsis, and then screening tools. So the why behind sepsis. So sepsis remains one of the leading causes of death in the U.S. It accounts for approximately 1/3 of all sepsis deaths. And sepsis creates significant clinical and resource burden to hospitals. So just to give you a little more context, a post-operative infection is defined as any infection that occurs within 30 days of operation and may be related to the operation itself or the post-operative course. It can involve the wound, it can involve deeper infections within the body cavities, or more distant infections such as pneumonia, CODI, or CLABSI. There are 15 million surgeries performed annually in the U.S., and post-operative patients are 10 times more likely to die from sepsis than a heart attack or stroke. That statistic really just kind of slayed me. 1 in 25 patients will experience at least one hospital-acquired infection during their stay. 1.5 million people are diagnosed with sepsis annually, and 1 in 3 hospital patients die from sepsis-related death. It remains higher for up to 5 years after hospital discharge. So the risk for sepsis for a post-operative patient, if they develop sepsis in the hospital, they have a higher risk of redevelopment within 5 years after discharge. And for every hour of delayed sepsis diagnosis, it results in an 8% increase in sepsis mortality. So we have some sobering statistics that we're dealing with. So the key elements to prevention when it comes to postoperative sepsis and septic shock is adherence to the SSI bundle, understanding who is at risk, and by that I mean looking at those specific procedures that have an inherently high risk, and then looking at those patients who have comorbidities. There are certain comorbidities that are associated with a higher risk of sepsis. And so understanding who's at risk when we're talking about specific procedures is, are you dealing with an emergent or an urgent procedure, or is this elective? You'll find when you review cases for sepsis that elective type procedures typically don't have a higher risk rate as much as urgent or emergent cases. And then the other thing to consider, is it a high-risk, low-volume procedure for your facility? So say you only do 2 to 3 colon resections in a year. You may be at higher risk of developing, or those patients may be at higher risk of developing sepsis because it's not a routine procedure that you perform on an annual basis. And then certainly looking at the comorbidities for these patients. You know, do they have any respiratory-related diseases? Are they diabetic? Do they have any type of renal impairment? Are they immunocompromised, or have they in the past been an organ transplant recipient? And then one of the things that surprised me too when I was doing research for this particular webinar series was a anesthesia class 2 or higher. So looking at those patients that have an anesthesia class 2 or higher, and potentially looking at remedies to prevent the development of aspiration or prevent development of pneumonia complications after surgery is something to consider. And then screening your patients for risk factors. You know, do they have an advanced age? Do they use tobacco? You know, they have a comorbidity perhaps of diabetes. Are they malnutritioned? Those are all areas that you can look at potentially coming in for surgery to help prevent sepsis from developing on those patients. So let's talk a little bit about procedures that have inherent risks for patients. So procedures with the greatest post-operative risk for sepsis, and I saw this in quite a few studies that I reviewed when I was doing the work around this webinar, involves esophageal surgeries. And as you can imagine, the esophagus and the trachea are so closely intertwined, plus you've got all of those great vessels around there that lead into the upper chest. And so that truly is a high-risk type procedure. Pancreatic, for whatever reason, because the pancreas is just kind of situated underneath the liver and close to the gallbladder and next to the stomach, pancreatic type procedures tend to have a higher sepsis risk. And then again, gastric procedures. Anytime you're doing an intra-abdominal type procedure, the patient has a higher risk of developing post-operative sepsis. And so procedures with highest mortality risk if sepsis develops. So the patients had the procedure and then they develop sepsis. The mortality rate is increased for those patients that have thoracic type surgeries, adrenal type surgeries, or liver type surgeries. And so those are just some considerations to think about when you're screening your patients for potential post-operative sepsis. So next I want to talk about the surgical site infection bundle and just looking at what the potential pieces are to this bundle. So it's looking at prophylactic antibiotics administered appropriately with start-stop time, normothermia maintained during the perioperative period, and some of those studies that I reviewed are actually taking this a little bit further and going up to 6 hours out post-op. So I'll be interested to hear from all of you on how you handle that piece. Supplemental oxygen provided pre, intra, and post-operatively. Certainly with all procedures, you want to maintain an appropriate oxygen saturation for patients. But there are certain patients where they're actually recommending that they have high flow oxygen and supplemental oxygen into the post-operative period. And that tends to be those people that have cardiothoracic surgeries and or those intra-abdominal surgeries. It's been found in some of the studies that if they have a higher oxygen saturation level, that it really does promote the healing process and help stave off sepsis. So something to consider there. And then preoperative skin antisepsis performed. So I want to hear from all of you folks that are on the call today. How often or how long has it been since you've pulled out the SSI bundle and reviewed it with staff or reviewed it against your protocols or procedures or order sets? Just go ahead and type into the chat box. Nancy, you indicated that you use it quarterly at the SSI team meeting. I'm glad to hear that. Are any of these pieces, Maggie, you indicated that you haven't reviewed it since you switched EHRs in 2 years. Maggie, is that because the SSI bundle is built into your EHR where it automatically ticks off, if you will, mostly? Okay. Nancy, you're asking for an updated copy of the SSI bundle. I'll certainly send that out. When we send out the slides and the link for the recording, I'll include that piece with it as well. So what other steps have you all taken to ensure that the SSI bundle is kept front and center for not only your OR staff, but for your providers? Do any of you have it posted in your ORs, laminated and posted in your ORs? Is it something that is reviewed at, say, team staff meetings? Is it something that's built into your EHR, or do you have a teaching piece that you provide to patients to ensure that they're aware of it as well? Chris, you indicated that it's built in, but you did a spot check a couple of years ago and watched for 6 months to make sure it was followed. That's a great idea as well. You can do spot checks, afterwards, or once you're first implementing. It's always recommended from a QI or a QAPI standpoint that when you implement a new process, or you're trying to ensure that a process is in place, that you routinely monitor it until you reach your threshold that you were shooting for, and then continually follow up and check on it afterwards. So great ideas. I'm glad that you guys are sharing. I love to hear that. So let's move on to some prevention tactics that you can think about. So we've all heard this analogy that an ounce of prevention is worth a pound of cure, and when it comes to sepsis, it really truly is. So for those patients that have respiratory type diseases, or you anticipate that there could be some type of a respiratory problem, have you considered having that patient meet with respiratory therapy prior to surgery to explain incentive spirometer, to explain potential changes to inhalers, to talk about things to watch for after they've had anesthesia? I can think back to those, when I was assisting with surgery, I can think back to those COPD patients, or those patients who had the asthma or the end-stage lung diseases type of things, and never failed. Within 48 hours, they were always complaining of shortness of breath, and they would have to go on antibiotics again, and they would have to have a change to their inhalers and to their, their pulmonary toilet regimen, that type of thing. So it's always amazing how much we can do preventatively before a patient has surgery to help on the backside to prevent any type of injury or illness after surgery. Consider having the patient meet with physical therapy. I know with most bone camp type programs, or it's required that before a patient has a total hip arthroplasty or a total knee arthroplasty, that they're meeting with physical therapy. But I would challenge you all to consider having physical therapy meet with the patients outside of joint arthroplasty, to really just give them an idea, those back surgery patients, and even those abdominal surgery patients, lap choles even, they don't necessarily understand the splinting process, making it easier for them to get up. And so sometimes bringing in extra people who have a good base knowledge on movement, and that can certainly help prevent any type of untoward outcomes. Encouraging smoking cessation prior to surgery, and then improved glycemic control prior to surgery. Even if those patients who have the 8 and the 9 A1Cs, even if we can get them to drop back down into the 7s, that's certainly going to improve their outcome, improve their healing, and improve the potential of them not developing sepsis, because they're so out of control during that post-op period anyway. So whatever we can do on the front side is certainly going to be beneficial on the back side. Have any of you taken to adopting and having patients meet with RT or PT or diabetic education before they have surgery? Maggie, you indicated no. Yeah, I have to admit that when I was doing bedside practice and was prepping patients for surgery and making the phone calls, I have to admit I honestly didn't consider any of these. I just wanted to make sure that we had their accurate list of medications and that we had their accurate list of past medical history, past surgical history, and of course allergies to medications. But I really didn't give much thought to the prevention side of it. And so when I was doing research for this webinar, this really kind of spoke to me, and I thought, you know, we probably could do a better job in promoting wellness before surgery to prevent illness after surgery. So next I want to talk about screening for sepsis. We're shifting gears just a little bit, but how many of you feel confident that your staff understand what it means when you're screening a patient for sepsis? Maggie, you indicated that you're not, that you don't feel comfortable with your staff, or you don't feel that they're understanding. Tiffany, you're indicating that you feel your staff is very confident in the emergency services on sepsis. Chris, you're indicating not 100%. Yeah, yeah, I agree with you, Joni. I know from my experience in the ER, that was always one of the things that we were looking for, is something other than sepsis, because we really didn't want to consider the thought that it could be sepsis. Nancy, you indicated that you have badge cards, though you can see that the new hires don't have sepsis in their CBO. Yeah, this is a totally different cat, because like you alluded to, Joni, I think when a patient comes into the emergency room, or they go back to their surgeon, or even as an inpatient, you know, we may not necessarily give enough credit in looking at what those symptoms are when it comes to sepsis. We're always trying to define, is the abdominal pain related to, well, you're not passing gas, or because you're retaining urine, or because you haven't stooled in a couple days, or, you know, you really haven't eaten enough, so that's why your bowels aren't working. And, you know, we always try and explain it away. At least that's what my experience has been. And so I think we need to do a better job of not just explaining to nursing staff and providers, but, you know, I think this is a great opportunity to also bring in patients and educate patients on the potential for sepsis, and really, while trying not to scare them per se, but really giving them an idea that if you don't feel right, make sure that I, as your bedside nurse or as your provider, truly do understand what's going on. And so, you know, when I think about those patients that are coming in through the emergency room, and you're looking at their potential history, I was always good to ask, well, have you been hospitalized recently? But I never really did take into effect or into account, you know, have you had a doctor's office visit? Or are you taking chemotherapy? Or have you been ill recently? One of the other things that I found in my research is, have you been to the dentist office recently? You know, those are all things that we can consider when we're taking our patient history to potentially identify, hey, I could be dealing with sepsis. You know, and the other thing to consider too is those patients who are taking corticosteroids or immunosuppressants or have had recent chemotherapy. Those patients are not going to present in a typical fashion when it comes to sepsis. So, you know, they may have hypotension, and they may have, you know, low blood counts, or they may not run a fever. But as they progress over that 12 to 24-hour period, they become deathly ill. And so what did we miss that we could have picked up on? symptoms that are involved when you're dealing with potential sepsis with patients is a temperature greater than 101 or less than 96.8, tachycardia of 90 beats per minute or more, tachypnea of 20 breaths per minute or more, leukopenia of less than 4,000 white blood cells, or leukocytosis of greater than 12,000, hyperglycemia greater than 140 milligrams per deciliter, and or altered mental status. You know, one of the scariest things for me was a patient who had come into the ER that I was caring for, and she was undergoing chemotherapy, but she said, she herself said, oh no, I think I probably just have a cold. I usually get a cold about this time of year, so I'm not too awfully concerned about it. The provider that I was working with wanted to contact her oncologist and say, hey, just so you know, Mrs. Jones was here in the ER. And she said, no, she was going to go see him. This was on a Friday. She was going to go see the oncologist on Monday. Well, I was off on the weekend, and when I came back in, I found out that the patient had come in 2 more times that same night, and they ended up flying her out, and she ended up having to be on a ventilator and unfortunately succumbed to the sepsis. But that was a big aha moment for me, because it was very important that I pick up on those subtle signs and symptoms of impending doom, if you will. And we could have been more diligent in following up with her and ensuring that she went to her oncologist or got transferred to the facility where she was having her treatments at, but it didn't work out that way. So again, just having an awareness really does help in identifying those potential septic patients. So when you're screening for sepsis, if the patient has 2 or more of the symptoms listed, then that's your cue to potentially start implementing your sepsis protocol or your sepsis order set. And when you're doing that, you're going to look at what their signs and their symptoms are, but then you also want to obtain lactic acid. You want to get 2 blood cultures. And I just want to throw this out there. How many of you have issues with providers just drawing 1 blood culture versus 2? Is it built within your order sets? Do you have something tied to your, when you pull your antibiotics out of your Pyxis or Omnicell, is there something on there that says to order 2 cultures? Maggie, you said you don't have that problem, that you always draw 2. Chris, I like that. You stole their option to only order 1. I like that. Jenny, blood cultures are ordered ×2. Joni, you indicated it's not a problem at your hospitals and it's also in your order sets. Good. I'm glad to hear that. What I found, at least early in my career, is that I would have providers who would only want to draw 1 culture. And my issue with that, as you all know, is what happens if that culture is contaminated? Then you're truly not identifying what the bug is. But I will say providers are getting better about drawing cultures rather than just slapping somebody on antibiotics right away and then drawing cultures. So it's been a learning experience all the way around, I think, not just for nursing staff, but also for providers. So when I was doing the research for this, there were some couple there were some screening tools that popped up that initially gave rise to the whole sepsis bundle. It proved that early goal-directed therapy really did decrease the mortality associated with sepsis, but then also proved that evidence-based practice does work when you're dealing with this particular condition. So there was the ARISE screening tool, there was the PROMISE, the process, and then the sepsis clock. Do any of you remember the sepsis clock when it came out? Or did you ever use it? When I was reviewing for this, I read through that, and I thought it was really interesting on how they had that set up. So, okay. Nancy, you indicated you're not familiar with any of these, and Joni, you indicate you're not aware. Yeah. I will tell you that these are what led to the bundle development that we have today. These were kind of the pieces that started. I believe it was the PROMISE tool that was utilized in Australia, and then the process tool was something that was used in England, and then there's been a couple places here in the United States that utilized it as well. So, all right. So one thing to consider when you're screening for sepsis is you've got the SIRS criteria, and then they meet 2 of the SIRS criteria, but then you have to distinguish if they are moving towards organ dysfunction or if they're moving towards full-blown septic shock. And so some things to consider when you're looking at that potential organ dysfunction is whether their systolic blood pressure is 90 millimeters of mercury or less, or their mean arterial pressure is 65 or less millimeters of mercury, or if their systolic blood pressure is decreased 40 millimeters of mercury from baseline. If the creatinine is greater than 2.0 milligrams per deciliter, or if their urine output is less than 0.5 mLs per kilogram for 2 hours. If they have a bilirubin of greater than 2 milligrams per deciliter, or their platelet count is greater than 100,000, a lactate greater than 2 milliosmoles per liter, coagulopathy, which indicates that they could be headed towards DIC of greater than 1.5, or an APTT of greater than 60 seconds, acute lung injury with a PaO2 or FiO2 of less than 260 in the absence of pneumonia as an infection resource, or acute lung injury with a PaO2 or FiO2 less than 200 in the presence of pneumonia as an infection resource or as an infection source. So things you can do, and I want you guys to chime in to tell me if you have these pieces built within your order sets, or if like you indicated that it's on your badge buddy, or how you have this set up. So IV antimicrobials are initiated as soon as possible. Identify or exclude potential source of infection as quickly as possible. That's not always as easy as it sounds. Prompt removal of an intravascular device. So I think about those folks that have had chemotherapy, or those folks that have had osteomyelitis. You know, they've got the PICC line and or they've got the port. And so prompt removal of those to determine if that's truly their infection. There's been several cases over the last 10 or 12 years where it's actually been identified that the lead wires to pacemakers have been the cause of septic-like infections. So that's another thing that you really need to consider. Fluid therapy, and then of course if they're progressing to organ dysfunction and or septic shock, vasopressors may be needed. And so with your order sets that you have at your facilities, do all of your order sets have these particular points built within there? Or consideration to something similar? I know in talking to the facilities that I work with, the two biggest points of contention seems to be the repeat lactic acid and or the fluid resuscitation piece. Would you say that you folks have those issues as well, or is it something different? Fluid resuscitation, lactic acid. Yeah, I've heard that too, Chris, about the pushback on the CHF because they don't want to throw them into full-blown heart failure. Do any of you have a reflex built within your order sets that when the initial lactic acid is drawn, that it will reflex and pull or order for the next lactic acid? Joni, you indicated that when the patient goes from ED to inpatient, the second lactic falls off. Maggie, you indicated that with the fluids and the IV antibiotics, you do okay, but not necessarily the removal of the intravascular device. Okay, no reflex for repeat lactic. Yeah. So those are all some things that you can consider, is potentially having a reflex built for the lactic acid. What ideas would you like to share when it comes to the fluid resuscitation piece and or the drop-off of the lactic acid? So Joni, you indicated that your lactic acid gets ordered now and within 3 hours. So you've developed a paper checklist for excellent handoff to ensure the lactic acid doesn't get missed again. I would be interested in receiving that if you could send that to us. And would you mind sharing it with all the panelists that are on today? I think it'd be great for them to see that. Something else I saw when I was reviewing for this webinar is is that some facilities have taken to where when you draw the blood cultures, it automatically reflexes and asks if they've collected a lactic acid. And or when they pull the antibiotic out of their ADC, it will automatically reflex and ask if they've drawn blood cultures and or a lactic acid as well. So those are just some other things to consider when you're talking about education and steps to promote sepsis identification. So when you're talking about broad spectrum antibiotics, the ones that are most commonly used are ceftriaxone, azithromycin, ciprofloxacin, vancomycin, and piptazo. Would you guys agree with your order sets that this is pretty common what you see? Okay, I'm seeing a couple yeses. I know my experience has been that this is typically what I would see. The piece that always got to me, though, was when I would have a doc that would order the ceftriaxone, and they would order the Vanco, and they would order the Pip-Tazo, and the patient would get all three of those, and then they would tell me that they're trying to cover for everything under the sun, and I'm sitting here going, yeah, that's okay, but you're going to cause more problems than you're going to help. You're increasing resistance, you're increasing potentially the problem of antibiotic-associated diarrhea, so might want to consider backing it down. Maggie, you indicated that those are all built within your order sets and they choose depending on the source. Good idea. So since you all indicated that fluid resuscitation can sometimes be problematic, I found this slide, or I should say this algorithm that was out there under one of the resources that I used, and it's included in the resources at the end of the slide deck. But it talks about adult septic shock. And so we all know how quickly patients can progress from SIRS to sepsis to septic shock, where you've got that imminent potential of increase in morbidity and mortality. And so this slide, I thought, really does a good job of explaining when it's appropriate to really think about fluid resuscitation for patients. And I will tell you that everything that I read is that the common theme is to go ahead and give fluids on those patients, regardless of whether you're concerned about fluid overload, because it's always easier to correct that after piece and pull that fluid off than it is to get enough fluid in them to prevent that organ damage. And so I liked that this slide presented and talked about the potential pieces that you really need to consider when you're talking about fluid resuscitation. I listened to a webinar last week, and it was talking about sepsis, and it was actually bedside nurses that were reporting out. But one of the things that they identified, or a couple of things that they identified, is that the goal of administering 30 milliliters per kilogram of crystalloid within the first 3 hours, they recommended that while that's a great guideline, they also recommended that that be individualized, that you not blindly just assume everybody can handle 30 mg per kg. And so they really recommended that nursing staff and providers collaborate and really make a determination as to whether it's appropriate for the particular patient that you're caring for to receive 30 mg per kg. Because you know as well as I do that some people are going to tolerate that well and others aren't. And so you really have to titrate that. And that's one thing I learned early on in my quality career. I had a provider tell me that these are merely just guidelines, even though they may be evidence-based practice, and that you really do need to take into consideration that individualization for those particular patients. So the other thing that I just want to add in here is there is a difference between a fluid challenge and fluids, a maintenance fluid for resuscitation. Just remember, a fluid challenge is typically given over a shortened period of time, 10 to 30 minutes, to expand intravascular volume rapidly, whereas maintenance fluid is usually given over hours. So something to consider when you're doing your education with your staff and considering the fluid resuscitation piece. The ultimate goal with fluid resuscitation is to keep a central venous pressure between 8 and 12 centimeters of water. So measuring that, through the ART line is something that really is very important if you're dealing with organ dysfunction and or septic shock. And then just know that patients who progress to septic shock and receive aggressive fluid resuscitation are still in a state of sustained hypotension and require frequent and continued monitoring. One of the things that I listened to last week on that sepsis webinar was the appearance of obese patients when you're dealing with fluid resuscitation for those types of folks. Sometimes it can be very difficult to determine how much fluid you want to give somebody that's, say, 200, 300, 400 pounds overweight. And this would be probably the best way to potentially look at making sure that you're within that goal. Maggie, you're asking about the goal for those that don't use ART lines and how to determine. I have to be honest, I did not see anything in that in my research, but I will certainly do some investigation for you and see what I can find out. My question to you is, would you keep those patients that aren't progressing from severe sepsis, or I should say organ dysfunction, into septic shock, or would you transfer those folks? Okay, probably not typically, but there are times when family chooses to do what you can locally. Okay. How many of you would keep a septic patient in your facility? Michelle, you indicate that you would. Jenna, you indicated you keep them often. Joan, you indicated that you keep septic patients. Okay. It's stable, Nancy. You keep them unless they're going into full organ failure quickly. That's what you indicated, Chris. Maggie, you indicated that it depends on severity, family wishes. Yeah. Okay. And in my experience, that's what I have experienced as well, is that if it's something that we always thought that we could turn around within 6 to 12 hours, certainly no greater than 24, we would sometimes keep the patients, or as you indicated, Maggie, it would be dependent on families' wishes. I can think about those nursing home patients who locally come to the hospital and family doesn't want them transferred out of town, but wants you to do everything possible before you consider moving them to end-of-life cares or potentially hospice. I will do some checking for you, Maggie, and see what I can find out on the alternative to CVP with ART-line. Okay. So some other things that you can consider when you're dealing with a potential sepsis patient is corticosteroids, immunoglobulins, anticoagulants, the need for mechanical ventilation, whether the patient's going to need to have sedation and analgesia, what's their glucose control, renal replacement therapy, bicarbonate therapy, VTE prophylaxis, stress ulcer prophylaxis, and then also consider what their nutrition's been. On some of these, when I was looking through this and it talked about other treatment considerations, some of these I could see as being too advanced for potentially our critical access hospitals, and they may administer them, but it's merely just to keep the patient stable enough to get them to transfer. Do any of you have these extra alternatives built within your order sets, or is this left up to provider discretion? I know certainly some of these we would give when the patient potentially moved from the ER and then moved to inpatient level of care. Chris, you indicated that some are in your order sets. Nancy, you indicated that you do not have order sets, that all prescriptions is only by provider choice. Yeah. Okay, so we're getting close to the end of our time. I want to hear from all of you. What are your biggest pain points when it comes to sepsis recognition, treatment, what have you? Is it staff education? Is it provider education? Is it the lack of continuity between the EHR and what needs to happen with your protocols? How many of you depend on your EHR versus a paper tool? Joan, you indicated that you still depend on a paper tool. Is that something you'd be willing to share? Just some information for me. How many of you have considered doing anything in your next QAPI plan, if you will, around sepsis? Have you identified a champion, either as a nurse or as a provider? Chris, you indicated that your prompt is through your EHR. And if they say no, then the bundle doesn't start. Nancy, you indicated that provider and staff education with new hires and contracted nurses, we do not have it in your CBO yet. When the sepsis alert fires, the nurses are not documenting their actions. Therefore, you're not noticing sepsis as a diagnosis used consistently and not in doctor's notes, okay? Joan, you indicated that you have a sepsis tag for the ED. That's interesting. I've not heard that before. Maggie, you indicated that you added it this year and you're trying to get systems going. Joni, you indicated that your EHR is helpful with BPAs, but you did implement a paper tool to ensure warm handoff occurs. Yes, thank you for sending the tool. I will make sure that that gets shared out. You've identified champions in both physician and nursing, and an interdisciplinary team is helpful once you drill down on the reasons for fallout. Yeah, I was just going to ask that question, Maggie, if anybody would be willing to share their packet of education. This is all about sharing, guys. The more we can get it out there and everybody at least exposed to it, the better off we'll be. So one of the, I'm going to go to a resources slide, and I don't know if any of you have had an opportunity yet or recently to go to the Surviving Sepsis campaign, or that is a resource that really is very valuable in talking about potential tools, talking about how to get engagement with providers, talking about how to get engagement for staff, somehow or some way removing barriers to ensure successes and early diagnosis and treatment for those patients. So if you all haven't had an opportunity, I've got a couple of links here that talk about the Surviving Sepsis campaign. One question that I had for you guys to consider for next week is if you have any cases that you would be interested in sharing, and they can be blinded. I would encourage you to blind them, but just to give an idea of some of the issues that you potentially talk about or that you see routinely in your facility, and the type of education that you did around that. I think it would be a good idea to get out there and share for everybody. Nancy, you indicated that some ED contracted physicians are using the SOFA score, and should you be using that, and that you stayed up to date with the SEP3 bundle. I'm glad you brought that up because that's one of the tools that I plan to talk about next week. But yes, you are absolutely right. It seems like the SOFA score is kind of the gold standard when it comes to identifying those patients that are progressing from the SIRS criteria into severe sepsis, if you will, organ dysfunction, and then into septic shock. And we'll talk about that next week. And then, Maggie, you wondered if it would be possible to send out emails of attendees for ongoing collaboration connections on our sepsis work. What do you all think? I think it's a great idea to collaborate and connect when it comes to sepsis, because it really is a high focus area, not just for CMS, but this can really have a huge impact on facilities. Joni, you indicated that a collaboration would be great. Maggie, I like that idea of a sepsis group on innovation. And Nancy, you indicated that there probably needs to be a statewide coalition. I can't say I disagree with that either. I think that's a great idea. Great sharing today, guys. I appreciate all of your input. So we're getting to the end here. I just want to say again, I appreciate all of your comments and your thoughts, and really like the idea of a statewide coalition and or a sepsis group. So I'll look into that, and maybe we can touch on that next week. Next week, as I said, we're going to talk about cases potentially. If you have cases that you want to bring and share and talk about, I plan to talk about the tools and what's involved in each one of those, the screening tools, and then just get a little bit more in depth into what some of your pain points are. So again, I appreciate your time, and if there's any other comments, feel free to throw them out there into the chat box. Otherwise, I will say that we are done for today. Stay warm, and I will see you next week.